Good morning, everyone. My name is Trish Secca, and I'm a Senior Nutrition Program Manager here at IAFNS. We're happy to have you here today and to offer you this webinar focused on the science and implementation of the low FODMAP diet. Before we get started, I'd like to tell you a little bit more about IAFNS. IAFNS is the Institute for the Advancement of Food and Nutrition Sciences. We're a nonprofit organization that mobilizes government, industry, and academia to drive, fund, and lead actionable science in the areas of food safety and nutrition, and we do that to advance public health. We fund external researchers and convene experts to support positive change. Our core values are illustrated here on this slide, and they guide everything that we do. Scientific integrity is centered on transparency, and we actively seek and enable collaborations, all for the benefit of public health. And you can learn more about our organization at www.ifns.org. Before we get started, I'd like to cover how to ask questions. This is the first format that the attendees might see on your meeting interface. Starting at the top, you'll notice an orange arrow. This arrow allows you to expand or collapse the control panel on your screen. When this window is expanded, you can type in your comments and questions, and in fact, we encourage you to engage with us in this way. Questions that you type in are only visible to the staff and not other attendees. Some of you with a different format of GoToWebinar may see this screen. Again, we encourage you to submit questions at any time during the presentation. Our staff will ensure that questions from the audience are addressed with any remaining time we have at the end of the webinar. The webinar has also been approved for one CPEU from the Commission on Dietetic Registration, and a link will be shared with all participants after the webinar in order to access your certificate. So let's go ahead and get started. Our first speaker today will be Dr. Kristen Roberts. Dr. Roberts is a registered dietitian nutritionist with 17 years of clinical experience in gastrointestinal conditions, gut rehabilitation, and nutrition support. Currently, she holds a joint appointment as an associate professor within the Division of Gastroenterology, Hepatology, and Nutrition in the School of Health and Rehabilitation Sciences at The Ohio State University. Kristen completed her PhD in human nutrition with a specialization in biomedical, clinical, and translational science, and she has an active research program understanding the impact of dietary patterns on chronic inflammatory conditions. Kristen is a fellow of the Academy of Nutrition and Dietetics and of the American Society for Parental and Enteral Nutrition. She's a certified nutrition support clinician and serves as the associate editor for nutrition and clinical practice. Please welcome Dr. Roberts.
Hi, everybody. Thank you for having me. I just want to start off by thanking the Institute for the Advancement of Food and Nutrition Sciences for inviting me to have this talk today. My talk is titled Designing Clinical Research to Understand the Interface Between Dietary Intake and Irritable Bowel Syndrome. And really throughout my talk, I'm going to try to cover these three main objectives. I'm going to start off by talking about some of the diagnostic criteria that has changed over time, and review some of the pathophysiology behind this condition. And I'm really going to focus in on some of the hypotheses related to the gut microbiota. A little bit different for this talk today. I'm going to end by reviewing some of the dietary assessment tools that we can use when designing clinical research studies, particularly aimed at FODMAP interventions, as that's going to be our second talk of the day today. And I'm going to be focusing on some of the strengths and limitations of these dietary assessment tools. So I'm excited to be able to kind of go through all of this with you over the next 25 minutes or so. So just to start, I do want to kind of classify what irritable bowel syndrome is. So this is most recently classified as a disorder of gut-brain interaction. Sometimes you might see this described in the literature as a chronic biopsychosocial disorder or a functional gastrointestinal condition. And all of these are appropriate and acceptable, and they all include that there's an abnormal sensory and motor response to stimuli. And that stimuli may be something that's ingested. It could also be stress or anxiety, as we'll see is built into some of these mechanisms of action. They all seem to stem to result in visceral hypersensitivity, where patients and individuals with this condition are feeling abdominal pain, bloating, gas, distension, and changes in their bowel movement pattern. Some papers have shown that there's even some low-grade inflammatory response that's occurring in this condition. And lastly, there are alterations in the gut microbiota. And again, I'm going to focus on that for the middle section of my talk today. But before I move on, I do want to just kind of preface that I'm not going to talk about a lot of the treatment options for irritable bowel syndrome, but I did want to highlight this one paper. It's several years old now, but they surveyed patients with irritable bowel syndrome and were asking the individuals to classify what they thought their causes or triggers were to their IBS-related symptoms. And over 80% of the survey respondents indicated that food was either the cause or a trigger of their symptom. And so those of you that are clinicians, you may see that these consults are coming in more frequently. And as we know that so many patients are feeling ill from the food that they're eating, they want to know what they should eat and what they should eliminate to try to minimize these symptoms. And so this has become at the forefront of many gastroenterologists' treatment plans, is trying different dietary interventions. So let's look at the Rome 4 criteria. Now, this has changed over time. We've seen Rome 2, Rome 3, now Rome 4. But Rome 4 criteria is our active definition of irritable bowel syndrome, and it's defined as recurrent abdominal pain that's happening at least 1 day per week in the last 3 months. And it's associated with changes in the frequency or perhaps the appearance of the stool, and that those symptoms had to have occurred 6 months prior to the onset of the diagnosis. So this definition helps to eliminate some of those cases of IBS-like symptoms that may be from a viral or bacterial infection that resolve quickly. So again, 6 months prior to diagnosis, we would need to see some of these abnormal symptoms occurring. So when the definition talks about differences in the way that the stool looks, in our GI offices and in many of the clinics that I've been in, you'll see a Bristol stool form scale that's right there on the wall. And this is just an example of that, where it classifies the appearance and the consistency of the stool, ranging from type 1 to type 7. And you can see that the IBS subtypes are actually using the Bristol stool chart to classify those patients that are constipation predominant versus diarrhea predominant versus a mixed presentation, and those that are unspecified. And I'm not going to read through those, but sometimes I think it's nice when you're looking at these definitions to actually have the Bristol stool chart in front of you so that you can get a more clear representation of what these subtypes look like. So why are we talking about this today? Most of you have probably seen various heat maps like this in other conditions outside of IBS. And what these maps show is prevalence data around the world. So the darker the color is in this particular heat map, the higher the prevalence is of IBS. And what you should note from this graph also is that we have lots of missing data. So anything that's not colored is missing data. So as we, our epidemiologists are studying prevalence in some of these other countries, we might see worldwide prevalence rates change. So if you've read through the IBS literature and you're trying to really grasp what the world prevalence is, one thing that's really important to note is that it's based on the definition that's being used in that study. So some studies that have been published, over 10 years ago, may be using Rome 2 or Rome 3 criteria and not the most up-to-date Rome criteria. So you might see prevalence rates as low as 5% worldwide, and some studies are showing over 10% of the world's population. So this is a lot of patients, right? And if you look at the quality of life literature, IBS significantly impacts patients' quality of life. And also this translates into healthcare dollars. So this is billions of healthcare dollars worldwide that we are seeing to the treatment of these symptoms. So if we can help figure out the best treatment strategies and design the best clinical research studies to answer some really important questions about mechanisms, we're going to be able to help a lot of people around the world. So what you're seeing here on this table is various working hypotheses or characteristics that we have pretty good basic science data on, and maybe we just haven't fully translated this into humans, of mechanisms about why IBS occurs in some individuals and maybe not in others. Some of the really strong working hypotheses are related to genetics or epigenetics, where we're seeing either gene mutations or polymorphisms that are contributing to changes in the permeability of the gastrointestinal tract. We know visceral hypersensitivity, as I mentioned earlier, is kind of at the forefront, and it's what's causing that. That is really the question. It seems that there's some immune activation by the mast cells that's increasing the release of some proteins, histamine proteases that might be contributing to this abnormal connection between the gut and the brain. And as I mentioned earlier, I really want to talk a little bit more in depth about dysbiosis, which is an imbalance between the good and the bad bacteria in our GI tract, and how that might contribute to some of the symptoms that we're seeing in IBS. So this is a really great image that pulls together many of those working hypotheses about the pathophysiology behind IBS. And this was published in Nature Reviews in 2016. And I'll just take a second and orient you to this. Right here in the middle of your screen, you can see the intestinal epithelium. And there's these tight junctions, these channels in between each of the epithelial cells. And right above those finger-like projections, you can see the lumen of the gastrointestinal tract where food particles are depicted, the microbiota, some bile acids that were secreted through the common bile duct into the lumen. And then what you're seeing depicted where these channels are in between the intestinal cells is that some of the microbes are actually penetrating through these channels and are likely increasing the activation of the immune system, where again, we're seeing all of these proteins that are being secreted by our immune cells that are impacting the way that the enteric nervous system is communicating between the brain and the gastrointestinal tract, that is likely responsible for some of that visceral hypersensitivity that we see in this patient population. But I want to focus on the very top part of this graph. Just looking at this picture, first off, you can see that the microbiota are all looking like they're the same species. And we know that there's a very diverse population that is in the healthy microbiome. And so this is a simplistic drawing of that. But typically, these tight junctions would not allow large molecules or proteins or bacteria to be able to penetrate through. But this is where you can see that maybe genetics is increasing that intestinal permeability. Some of the basic science data has pointed to CDH1 and CDC42 as being two mutations that are contributing to an increase in the intestinal permeability that might be allowing those microbes to come into contact with our immune system. All right, so I'm going to divert just a second here into talking a little bit about the gut microbiota. And this is a very generic kind of drawing that was published in Nature Review, but I really like it. And it goes to at the very top of this image, you can see all the dominant phyla that are present and all of the families of microbes that are present within those phyla. And then we can get even more detailed and talk about the species. The way that these bacteria are surviving in our gastrointestinal tract is based on the change of pH. So we know that the pH increases as we get further away from the stomach, and our availability to oxygen decreases as we get further away from the stomach, and that contributes to which species are more likely to thrive in that environment. And when we look at data from the Human Gut Microbiome Project, that was a big project that was funded in the US, looking at what species are in the microbiota and are starting to get some more data on what those species are actually doing. One of the things that I find very interesting when reading the literature that's related to the gut microbiota is depicted here in this cross-section of the gastrointestinal tract, where you can see the different families of bacteria that are present in the folds of the GI tract, which are those areas that are really responsible for the absorptive capacity, and how that differs from the digesta. So when we're doing animal microbiota studies, you might see the scientists look at the tissue-associated microbiome and compare that to the luminal or fecal microbiome. And we don't expect those to be the same. And so it's really important that when we're reading the literature in this area, that we understand where the sample was taken from so that we understand how to put that into context with the rest of the literature. So why do we care about this in this IBS talk? We know that there is an overlap in those that have IBS and also those that have a diagnosis of small intestinal bacterial overgrowth. And so I just wanted to comment on SIBO for a brief second here. Remember that the gastroenterology societies have deemed that the small bowel aspirate is the gold standard for diagnosing SIBO. But there are lots of limitations to this that we're not going to talk about today. But one being that many patients that are getting endoscopy are consuming bowel prep prior to that. And we know that bowel prep can change the types of bacteria that are present. So many individuals have gone to using hydrogen breath tests, which are when a patient is given some type of substrate that will be then ingested, and the bacteria in the gastrointestinal tract will start to chew that up and ferment. And you can look at the gas production within 90 minutes, and you can see the cutoff levels here, either for hydrogen levels being greater than 20 parts per million or methane levels being greater than 10 parts per million to give us that diagnosis of SIBO. You should also note that these definitions and cutoff values have changed over time as well. So if you're looking at older studies, it is important to note what their definition is of SIBO to help us understand the prevalence of SIBO in those with IBS. And it's also important to note that the definition of the number of colony-forming units per milliliter has also changed over time too. And we tend to use here in the US, the ACG clinical guidelines, which do quantify 10 to the third colony forming units as our diagnosis of SIBO. I'm going to go in a little bit later in the talk and talk about some of the prevalence data that where we see the overlap of these two conditions. But I just wanted to set the stage for the SIBO conversation. All right. So what else about the microbiota and this dysbiosis or this imbalance? When you look at studies in IBS that are also trying to quantify if SIBO is present and looking at the types of microbes, it does seem that SIBO is more prominent in those with IBS compared to healthy controls, and that we see lots of different signs of dysbiosis. Some are related to different families being in a higher magnitude or a lower magnitude compared to healthy controls, or the ratio to different types of phyla are different compared to healthy controls. And so it seems to be that dysbiosis is common in IBS. The exact prevalence, I'm not 100% sure we know because of lots of the limitations with testing that I had just mentioned on the previous slide. But I also wanted to mention one really interesting study that was just published 2 years ago, where the researchers took the human microbiota from patients with IBS and put the microbiota into a sterile gastrointestinal tract of mice. And then at necropsy, they looked at different markers of visceral hypersensitivity and intestinal permeability, and they did indeed see that that was present after, implanting those microbes. And so it continues to build those hypotheses in these animal models that the microbiota may be very much linked to the intestinal permeability and the visceral hypersensitivity that we see in this patient population. All right, my last comment on the microbiota that I wanted to stress, because I'm seeing more and more of this in my clinic, especially since the pandemic, but many of us have probably heard of the diagnosis of post-infectious IBS. I often get a lot of these referrals from the patients with IBD that are in remission from biopsy, but yet they're still experiencing abnormal GI symptoms. And we started seeing a big increase of this in our clinic also. After those had been exposed to COVID, we saw a small percentage of those patients popping into our clinic with IBS-like symptoms as well. And this is a really great depiction of what we're seeing in those different patient examples that was published in Springer Nature just a couple years ago. And it's showing that, our healthy microbiota, and then we get some type of acute gastroenteritis that changes our microbes. And most people completely recover from that infectious process. But there is about 10% of individuals that may start to see that those changes in the microbiota are activating their immune system, causing changes in motility like diarrhea or constipation, leading to a dysbiosis and some of those visceral changes and symptoms like the abdominal pain, bloating, gas production, and changes in bowel movement pattern that we see in IBS. So another kind of overlap with where we see the microbiota impacting some of these mechanisms for developing these symptoms. So this slide might seem a little bit out of order, but I did want to share that it is really important for us to understand that many of these symptoms of IBS overlap with other conditions and other syndromes that we often see in gastroenterology. And so it's important that if we're seeing patients that don't seem to be responding well to our interventions, that we're thinking about, is SIBO present? Is this patient at risk for bile acid malabsorption? And you can see this list. Well, when it comes to SIBO, these papers, again, are estimating anywhere upwards of over 50% of patients with IBS may also have a diagnosis of SIBO. So this could be present as well. With bile acid malabsorption, this seems to occur in about 20% of patients that have IBS, and it's more common in those that are diarrhea predominant. Histamine intolerance, we don't know too much about. There's not a lot of literature in this area, but it keeps coming up at our national conferences every year that I think people are really interested in this topic and understanding foods that increase histamine release in the gastrointestinal tract and really trying to understand the prevalence of this. In those patients that may be experiencing their symptoms for a lifetime, we might think about congenital sucrase isomaltase deficiency. And those constipation patients, they're a really challenging group. And many of them may have pelvic floor dysfunction. So again, if we're not seeing really good responses to treatments that have pretty high response rates, we might need to think outside of the box a little bit and consult with our gastroenterologist experts to see if any of these conditions might be present. Okay, so now I'm going to shift topics just a little bit and talk about designing nutrition-based interventions for irritable bowel syndrome. So my interest in this really stemmed from a lot of my doctoral work where I was working on trying to categorize dietary patterns and understanding exposure to different dietary interventions. And really the mindset was trying to mimic what we see in pharmacology-based interventions to see if we can mimic some of that in our dietary interventions. So one of the biggest challenges here is that there's lots of different ways to categorize dietary patterns. And what one dietary pattern might quantify well, another might not do as well. So it makes it challenging to compare each of these different dietary scores. Also, we have very few nutritional biomarkers. This has been a big push for the NIH here in the US to really focus on trying to fund nutrition-based research that is aimed at identifying nutritional biomarkers so that we're better at designing studies to figure out how diet is impacting various outcomes. So when you're looking at this graph, the first thing we need to think about is how should we be characterizing our dietary patterns, particularly in IBS-related research? Do we have any compounds that we can be measuring to look at exposure to our dietary intervention? And then when we're looking at selected health outcomes, which health outcomes should we be looking at? Are we looking at improving the symptom severity in our patients? Are we looking at improving quality of life? These are things that we need to think about. What's most important to the patient population? So the next slide here, I know most of you are likely familiar with, and I'm not going to belabor this, and it may even be a little bit challenging to read, but We have many different dietary assessment tools that we use in nutrition research. We've got records, recalls, food frequency questionnaires, maybe specific surveys, and they all have their pros and cons related to the accuracy of the data collection. But what I want you to focus in is on the last column and really think about these dietary assessments when it comes to FODMAP exposure. I know we haven't talked about FODMAPs yet, but I want you to think about that when you're listening to the next talk. How do we measure FODMAP exposure at baseline? How do we know that our dietary intervention is actually changing the amount of FODMAPs that we are, delivering to the individual? How can we market or look at different health outcomes related to that exposure? And we really don't have any great options for really good nutrition assessment tools that are accurately quantifying. And that's partially because this area of research is still in its infancy, and a ton of work has been done all around the world at trying to improve these measures so that we can continue to work on our design of clinical research studies. All right, so I have a couple minutes left, and I just wanted to walk through very quickly how the development of the low FODMAP diet came to be. So if you're not familiar with the low FODMAP diet, FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And really the basis stemmed from understanding that excess fructose malabsorption led to a lot of IBS-related symptoms, and so did the fructans that were undigested in the GI tract. And so the initial research question by investigators was, what happens if we promote fructose absorption or remove the excess amount of fructose in our patients with IBS's diet while controlling the fructan intake? And this is from one of those original papers. This is from 2006, where they looked at individuals that were adherent versus not adherent to the dietary recommendations from an RD dietitian-led intervention. And what you can see is that those patients that were adherent to the dietary advice of improving the absorption of fructose while eliminating fructans had a much greater change in their symptoms. So they were getting better in almost every single one of these symptoms that we tend to classify as related to IBS. And then what the research did is they looked at just the individuals who were 100% adherent to the diet. And then they started looking at the changes in between those that were adherent and non-adherent again, and seeing the proportion of patients with symptom response. And again, you could see that those patients that were feeling better were more likely adherent to that dietary intervention. So both of those kind of asking similar questions just in a different way, but showing consistent results. So next, later on, the researchers looked at, is it just one of these groups of carbohydrates? Is it just fructose? Is it just fructans? And what happens if we mix them together? Do we get an even greater symptom severity in those individuals? And you can look at the bars all the way through, but if you start looking at the overall section where it says mixed, you can see that the symptom severity is the highest, that black bar. And compared to the placebo, this is significant. So we knew that there was this additive effect when we were consuming both of those carbohydrates at the same time. So fast forward, almost 20 years later from some of those initial studies, there's a lot of research out there looking at different dietary interventions in comparison to the low FODMAP diet. Some of them show no difference. Most of these are single studies, while the meta-analyses and some other single studies are showing that the low FODMAP diet is superior. Different dietary interventions are used. Some of these interventions were a sham diet. Some of them were a high FODMAP diet. Some were looking at the diet of the population in which this is being studied as the control. But it would be really nice for us to be able to understand, again, what was the exposure to FODMAPs at the beginning of the study? How did that change throughout the study? And once we have some great biomarkers, it'll make it even stronger that hopefully we'll continually see more consistent results being produced. Okay, so my last slide here is looking at a call for research. So One of the things that would be really wonderful for those of us that are doing FODMAP research is if we had a comprehensive database that was publicly available. Being able to attach FODMAPs to some of our nutrition databases that are available in our various countries would help us be able to quantify FODMAPs throughout the dietary interventions. We've got a lot of great papers that publish different FODMAP contents, but the assays that might be used in one lab may differ from another. And having some kind of comprehensive database would really help push this field forward. Also, I think when we're reviewing manuscripts in this area, that we really need to think about how the dietary assessment is discussed in the methods and how dietary compliance is recorded. We keep records on all of our patients in my institution that follow the low FODMAP diet, and we see a significant variability in the compliance with this. When it's a feeding study, we can kind of assume that there's really good dietary compliance, but when it gets out into the free living populations, compliance, is really important for us to understand as researchers when we're designing these studies. And then lastly, some of those select health outcomes, looking at symptom severity, quality of life, healthcare dollars. These are all really big areas that are of interest for us to try to improve as we're designing these research studies. All right. And that's the end of my talk. Thank you very much.
Thank you very much, Kristen. I appreciate you, and I think that you did a great job providing information about the etiology of IBS and the opportunity for the FODMAP diet to help alleviate symptoms. So that's a great lead in to our next speaker. So our next speaker is Ijmet Mann, and she's an accredited practicing dietitian, nutritionist, and social media executive at FODMAP Friendly, which is based in Victoria, Australia, where it's very early this morning. Thank you for joining us. She graduated Deakin University with a Master's of Dietetics and Bachelor's of Health Sciences, majoring in Food Studies and Nutrition. Ijmet is a FODMAP-trained dietitian, having completed both the FODMAP Institute IBS Management, the Low FODMAP Diet course, and Monash University's Low FODMAP Diet for IBS, its online training course for health professionals. She's passionate about helping and supporting people with gut health issues to identify foods and habits that are causing trouble and to provide personalized support. Her talk will focus on the practical implementation of the FODMAP diet. Let's welcome Ijmet.
Good morning or good afternoon to everyone in America. Thank you to IAFNS for having me, and thank you, Kristen, for setting the scene for this second part of the talk. So today we'll be talking about the low FODMAP diet and the management that it has in IBS. So the second half of this webinar will discuss the low FODMAP diet, the indications and the contraindications of implementing the low FODMAP diet, nutrients at risk if we're following the low FODMAP diet for a long term. And we'll also discuss some practical tips such as grocery shopping and tips for success. So firstly, what are FODMAPs? So FODMAPs are poorly absorbed short-chain carbohydrates. They are found naturally in some foods, and they're also sometimes included as additives. They malabsorb sometimes and trigger some gut symptoms for people that have IBS. So FODMAP is an acronym. It stands for fermentable oligosaccharide, disaccharides, monosaccharides, and polyols. And on the right-hand side of the screen, you can see some foods that contain some of these FODMAPs. So things like onion and garlic, milk, honey, apples, and mince. So on this slide, you can see some foods that are high in oligosaccharides, which is broken down into fructans and GOS. Some of the common ones that you may have heard of are onion and garlic, for example, and legumes and lentils. But there are other ones like cashews and pistachios, dried fruits, and ripe bananas, for example. In terms of disaccharides, we're looking for foods high in lactose. So this is things like cow's milk, cream, custard, evaporated milk, ice cream, and those really soft cheeses as well, such as ricotta and cottage cheese. Monosaccharides, we're looking at foods high in excess fructose. So this is where the fructose is higher than the glucose level. So things like honey, fruit juices, some fruits such as mangoes, apples, and pears, and again, dried fruits, as I mentioned before. And lastly, the polyol group. So this is things like sorbitol, mannitol, and other polyols. So sorbitol and mannitol are found in foods such as fruits and vegetables, but they're also sometimes found as additives as well, labeled as E420 and E421. And then there are other polyols also that are used as additives, especially in those sugar-free foods and drinks, like sugar-free gum and sugar-free soft drinks. So now that we know what FODMAPs are, we can move on to the low FODMAP diet. So the low FODMAP diet is a 3-phase diet. So the research, as Dr. Kirsten mentioned, it began way back in the early 2000s, and it has been tested and found to be one of the best treatments for IBS. Even though there is no cure for IBS, it is one of the best well-known treatments for it. The low FODMAP diet should always be followed under the guidance of a trained FODMAP dietitian, and the research is always growing, as is the food and drink market as well. So as I mentioned, there's 3 phases of the low FODMAP diet, but before we discuss the 3 phases, we need to ensure that the person is suitable for the low FODMAP diet. So this means confirming the diagnosis of IBS and ensuring this suitability. And this can be done via a nutrition assessment. So as we mentioned earlier, there are some conditions that can overlap with IBS. So some of these can be seen on the screen here, and some were already mentioned by Dr. Kirsten. So it's important to rule out any of these sinister diseases prior to moving on with the low FODMAP diet. So if you're the dietitian in this case, it's always important to refer back to the GP or the gastroenterologist to rule out any of these conditions before continuing with the low FODMAP diet. In terms of the nutrition assessment, a dietitian's assessment should always include the following. So always checking for the intake of common GI irritants. So these are things like excessive alcohol intake, spicy foods, high-fat foods. Also eating behaviours, is the individual regularly skipping meals, and also screening for signs of disordered eating and any previous advice that they may have been given by either another dietitian or any other health professional as well that may need to be taken into account while following the low FODMAP diet. So if you're confident that the diagnosis for IBS is accurate and that they will benefit from the low FODMAP diet, then we can continue on to implement the low FODMAP diet, making sure that the individual is presenting with those digestive symptoms that were mentioned earlier, such as bloating, excessive gas, diarrhea, constipation. They're all symptoms of IBS. And if they are unable to manage these symptoms with baseline healthy behaviors, such as having those regular frequent meals and eliminating common gastrointestinal irritating foods such as alcohol and spicy foods, for example, and also making sure that they have the mental and the physical ability to alter their diet without damaging their health. The low FODMAP diet can be quite restrictive, and it's very important that the individual is able to manage their diet appropriately and find appropriate low FODMAP alternatives to ensure that they aren't facing any nutritional deficiencies moving forward. If, on the other hand, you do notice any red flag signs or symptoms and any of the foods, any of the overlapping symptoms that we spoke about earlier, or if you think it could be any of those other conditions such as celiac disease or IBD, if the individual is underweight or losing weight or already have existing dietary restrictions or are at risk of nutritional adequacy, then it's important to note that they may not be suitable for the low FODMAP diet. in addition to this, as I mentioned, if they have poor capability to apply the diet, for example, if they don't have control over their own food choices, aren't able to plan and cook themselves, then again, they may not be suitable. And also, if they are pregnant or planning pregnancy, it's important then again that they may not be suitable for the low FODMAP diet. So if you have assessed their nutrition and there aren't any clear red flags or contraindications, then we can begin the low FODMAP diet. So as I mentioned earlier, it's a 3-phase diet. The first phase is the elimination phase. So this is a 2 to 6 week phase. So this involves removing all of the high FODMAP foods from their diet. And it's very strict, and it determines by eliminating all of these foods if their symptoms improve. If they do improve, then we can move on to phase 2, which is the reintroduction or the challenge phase. So this is where you would determine exactly which FODMAP groups are triggering the individual's symptoms. And you want to reintroduce each FODMAP group at a time to be able to figure it out this way. And this can take about 2 to 3 months as well, where we're reintroducing one group at a time. So it's important to regularly check in with your dietitian again to make sure there are no nutritional deficiencies as well. And lastly, once we know exactly which of these foods are the individual's triggers, then we can personalize the diet to that individual and increase the variety in their diet. And we can limit the foods that we know trigger their symptoms and reintroduce the foods that are okay with them. So now we can move on a little bit in more detail in terms of each of the phases. So phase 1, as I mentioned, is the elimination phase. So this is where we want to eliminate all of the high FODMAP foods from the diet. So this is the list that I showed earlier in the presentation. And every single one of those we want to completely eliminate and replace with low FODMAP alternatives so that there are still alternatives that the individual can have. Then this is only a short-term period, so it's 2 to 6 weeks. It's enough time for the client to trial the diet and see if they notice any changes in their symptoms. If they do, then we move on to phase 2. If they don't, then it may be something else that's triggering their symptoms, and it may not be IBS or the low FODMAP diet that's going to help them. It's also important to set the stage with the clients as well. So approximately 50 to 80% of individuals will respond to the low FODMAP diet and the first phase, which is the elimination phase. And they may not notice a 100%, complete low FODMAP symptom improvement, but hopefully you do want to see some improvement in their symptoms. And some improvement is enough to move on to phase 2 as well. If they haven't noticed a difference, then again, you want to troubleshoot, make sure that they have eliminated all low FODMAP, high FODMAP foods and replace them with low FODMAP foods. And again, if you think it's not that, then you want to refer them back to their GP. So here are some examples of swaps that can be made. So some extremely high FODMAP foods are onion and garlic, wheat bread, apples, pasta, and milk. And on the right-hand side, you can see low FODMAP alternatives. So chives or the green ends of green onions are suitable alternatives for onion. For garlic, you can use garlic-infused olive oils. Wheat bread, you can use true sourdough or gluten-free bread. For apples, you can use alternative fruits such as oranges. Pasta, you can use gluten-free pasta, and milk, lactose-free or some plant-based milks as well. Now, there are 2 sort of approaches to the low FODMAP diet. So the full elimination is what we've already spoken about, where you want to completely get rid of every single high FODMAP food and replace it with low FODMAP alternatives. And this is what you kind of want to focus on and aim for, but in most cases to make sure that you're getting the best treatment possible. However, we can also use the gentle approach as well. And this is where you would reduce only the highest FODMAP groups that are found in the client's diet. So you would take a diet history and from there eliminate the really high FODMAP foods. So this is less restrictive. and it's suitable for those groups of people that may be pregnant, or especially for children and people that are either hesitant or unwilling to change, or they don't have the ability to change, again, don't have as much control over their foods. So when we're following the low FODMAP diet, some tips in terms of grocery shopping is to familiarize yourself with low FODMAP foods. So get acquainted with the list of foods that are low in FODMAPs and those that should be avoided or limited. And this will provide you with a foundation of making appropriate choices. Secondly, planning your meals and making a shopping list. So when you plan your meals in advance, consider the low FODMAP ingredients you can include. This will help you to create a comprehensive shopping list and avoid buying items that might trigger your symptoms. Thirdly, you want to stock up on low FODMAP pantry staples. So keep your pantry well stocked with low FODMAP essentials like tinned tuna, rice, gluten-free pasta, canned tomatoes, without onion and garlic, and low FODMAP condiments as well, such as soy sauce, without wheat, and suitable snacks like rice crackers or plain potato chips. And lastly, reading food labels carefully. So be diligent about reading food labels to check for ingredients that are high in FODMAPs. So things such as onion, garlic, wheat, high fructose corn syrup, and avoid products that contain these ingredients on their ingredient list. And then going hand in hand, looking for low FODMAP recipe books, websites, or smartphone apps that provide meal ideas and shopping guides can be really, really helpful to diversify your meals while adhering to the low FODMAP guidelines. So when you are shopping, you can look for the approved FODMAP-friendly certified logo, which you can see on the top foods there. So that way you don't have to read long ingredient lists. See, these foods have already been tested and certified to be low FODMAP within the serving size that's listed on the food product. And secondly, we've got our low FODMAP app as well, and website that you can also have a look at, which has some meal ideas and recipes that we release weekly too. And on this screen, you can see a further list of some FODMAP-friendly certified products as well as some recipe ebooks that you can follow too. Now, while we're following the low FODMAP diet, there are some nutrients that can be of concern if we follow it for too long. So firstly, we'll speak about fiber. So fiber is an important part of the diet, as we all know, especially for those with IBS, as it helps to stimulate bowel motion to promote a healthy digestive system. And eliminating those high FODMAP foods, such as fruits and vegetables and breads and grains, can significantly really reduce the fiber intake. So it's really important to make sure that we are supplementing with low FODMAP alternatives. Secondly, calcium. So calcium is important for bone and teeth strength and muscle contractions, maintaining your heartbeat. So calcium requirements can be met easily by opting for lactose-free dairy foods. And also, if for those following a vegetarian or a vegan diet, we can swap for some plant-based foods as well, just needing to make sure that they are fortified with calcium as well. Protein and vitamin B12. Again, as we know, FODMAPs are found in carbohydrate-containing foods, so most meats are usually okay and don't contain any FODMAPs. So for those that are vegan or vegetarian, protein and vitamin B12 can become a nutrient of concern if you're not consuming meat and if you're not finding low FODMAP alternatives as well. And lastly, iron. So iron is found in those high FODMAP foods such as beans and legumes and cashews and iron-fortified wheat cereals. So it's important, again, to meet those iron requirements for those that are vegetarian and vegan following the low FODMAP diet. And again, this is why it's really important to not stick to the low FODMAP diet forever. This should only be a short-term phase of the diet, 2 to 6 weeks maximum, and then moving on to phase 2 of the diet. So phase 2 of the diet. Again, this is where you want to assess the symptoms of the individual, troubleshoot the diet as required, making sure that the individual is sticking to the complete low FODMAP diet to ensure the symptom relief. And then if their symptoms have improved, this is where you want to begin the reintroduction phase. So as I mentioned, no later than 6 weeks from commencing the elimination phase to avoid any nutrition nutrient deficiencies. So each FODMAP subgroup is challenged individually while continuing the low FODMAP diet in the background. And you want to monitor the symptoms per challenge to see which FODMAPs are tolerated and in which amounts. So to understand this a little bit better, we can work through a FODMAP challenge in a second. But the importance of reintroducing these FODMAPs is to understand your personal FODMAP triggers, because everyone is different. Some people may be able to tolerate some things while others may not. Secondly, for the nutrition and the prebiotics and nourishing the gut microbiome. So all of these high FODMAP foods are actually really important for the gut microbiome, and to make sure that they come back into the diet, it's important to reintroduce FODMAPs. And thirdly, to make life easier, to make eating out easier and more sustainable, to make traveling easier, it's important to reintroduce these FODMAPs back into the diet. So as I mentioned, we'll work through a FODMAP challenge together. So we'll go through honey as one of the challenges, as excess fructose. So as I mentioned, you always want to stick to the low FODMAP diet in the background. So everything else should still be the complete low FODMAP diet apart from the test food, in which case it's honey. So basically what you want to do is, as I mentioned, baseline, stick to the low FODMAP diet. Day one, you want to test a small dose of honey. So for example, 1.5 teaspoons. And you want to monitor your symptoms throughout the challenge. So the individual or the patient will be monitoring their symptoms as they go. I personally like to use a smiley face type of format, where if it's a happy face, they can move on to the second dose. If it's a medium face, it kind of means that they had some mild symptoms, but they were manageable and still are able to move on to the second dose. However, if they circle the sad face, that means they had really bad symptoms and they should stop there, and they know that their limit is just that 1.5 teaspoons of honey. If their symptoms were manageable or didn't have any symptoms at all, we can move on to test dose 2. It may be feasible to take a rest day in between for some people. Other people can move on directly onto dose 2. So this is case by case dependent. So dose 2 would be a higher dose of honey, so a whole tablespoon of honey. Again, assess your symptoms as you go, circling those smiley faces. And then again, a rest day. And then lastly, test dose 3, which is 2 tablespoons of honey. And this is a very high dose and unlikely that you would be having this much in one go anyways. But just to be able to assess how much you're able to have, we do test all 3 doses. Then you have about a 2-day washout period again. So sticking to the complete low FODMAP diet for 2 days before testing the next food. Now, once we have the results for these, we can move on to the personalization. So the personalization phase involves interpreting the challenge results. So we can identify which of these foods were tolerated well, which were not tolerated. And from there, we can liberalize the diet and expand the diet variety. So we can include some of those foods that were tolerated well, and we can limit the foods that weren't tolerated well. Now, there are some other things that can be used as well, such as enzymes and prebiotics and probiotics to consider as well in terms of long-term IBS management, especially when eating out and things like that too. But it's really important to liberalize the diet here after the results. So how do we interpret the results? So as I mentioned, if there were little to no symptoms at all, then that food becomes an eat freely food, and the individual can have as much of that food as they like whenever they like. Secondly, if they had moderate to severe symptoms to a small dose, then they have to treat that food with caution. That means they may be able to have a small, very small dose here and there, and they know to stick to the low FODMAP diet or foods that won't trigger the symptoms for the consecutive days until their symptoms are past. If the individual has moderate to severe symptoms in dose 2, that means they can eat it in small portions or as tolerated, and this may involve maybe skipping a day in between those meals. And lastly, if they had moderate to severe symptoms at the large dose, which is dose 3, That means they can enjoy it in moderation, or if they have any symptoms at all, again, enjoy it in moderation. So in terms of some tips for success, as we mentioned earlier, it's really important to stick to the low FODMAP diet for a short period of time and not forever, to ensure that there are no nutritional deficiencies. Again, also reiterating, it's a low FODMAP diet, not a no FODMAP diet. So we can still include small doses of FODMAPs, just not high FODMAP foods. A good example of this is cheese. So 40 grams of cheese is still low FODMAP. Once we exceed that, it becomes high FODMAP. So we can still have cheese, but just not too much of it. Thirdly, nutritional adequacy. So we already mentioned this earlier as well, ensuring that we're finding appropriate low FODMAP swaps for those high FODMAP foods so that we aren't, acquiring nutritional adequacy. And lastly, it's important to complete the diet under the guidance of a trained low FODMAP dietitian as well. I also would like to touch on the FODMAP-friendly smartphone app, as we already did earlier. It's free to download, and this has a list of all of our tested foods, both food products and also foods, as well as you can see on the left-hand side, apple. So you can see exactly which FODMAP group it's high and low in as well. And you can find the exact serving size of how much passes and how much you can have on a low FODMAP diet.
It's great. Thank you so much for your presentation, but we're out of time for today. And unfortunately, we're not going to have any time for questions. I will say, though, that for those that have submitted questions, we will share those questions with our speakers and ensure that they can address them with you directly. As of now, if you have any questions, I would just say you can connect with us at IAFNS to help, where we cultivate a science where a future where science and evidence drives decision making. I want to make sure that you know how to reach us. If you, you can see my son. How you can reach us if you have any questions, you can contact me directly at trisek@ifns.org, or you can connect with us through our website and on Twitter and LinkedIn. So I'd like to thank our presenters very much. And that's all for today. So thank you very much, Kristen and Ijmeet. And thank you all for sticking with us, and have a great day.
Thank you.
Thank you.